We know that kids get concussion in lots of different ways. Sport and recreation is probably one of the leading causes in childhood, but kids get these injuries in all sorts of unexpected and hard to code ways. And I'm assured that the child on the lower right actually was okay. Brotherly love, I think, is what we're seeing there. Concussion's a public health burden, without a doubt. Very large numbers of kids and adolescents get these injuries every year. In the US, which actually has better data available than Canada, about 600,000 kids 0 to 14 seek hospital attention for these milder injuries, but the numbers are definitely in the millions. It's been estimated that 1 to 2 million sport-related concussions happen annually in the United States alone. Concussion and mild traumatic brain injury has been identified as a target by all the major health organizations and health research funding organizations around the world. It's a hot topic in the media and scientific literature until the pandemic, and nowadays it's happening again. It's rare you don't see an article about something about concerns about concussion or repetitive impacts, whether it's second impact syndrome, persisting symptoms after concussion, or chronic traumatic encephalopathy. So even if a small proportion of youngsters with these injuries have negative outcomes, concussion is a significant public health burden. But what about Alberta? So we published 2 articles back in 22 and 23 about the epidemiology of pediatric concussion in Alberta. And this will set the stage for the intervention study that we're going to talk about. This is a picture of Crystal Whittle-Vrongel, who is a graduate student who worked with me and Jen Zwicker to lead these papers. We found a very interesting phenomena that's occurred in many other jurisdictions in Canada, including Ontario and BC, where from about 2010 onward, there was a doubling in the incidence of diagnosed concussion over time. This was data from Alberta Health Services going back to 2004 through 2018, with all diagnoses of concussion in children 0 to 17. And what we saw was an incidence change from about 600 per 100,000 to over 1,200 per 100,000 as of 2018. This is probably not because concussions actually became more common, but because with all the popular press about concussion, there was an increasing recognition and awareness of the disorder. We saw a similar but smaller increase in the diagnosis of unspecified injury of the head. This is important because this diagnosis sometimes is used in place of concussion in younger children. This is data looking at incidence by age across the 14 years of the study. And what you clearly see is a significant peak in the use of the diagnosis of unspecified injury of the head in young children, particularly under the age of 4, whereas you see a corresponding increase in the incidence of concussion as we go into the teenage years. This is consistent with the known epidemiology of concussion. But the CDC, among others, has shown that a significant proportion of kids who are diagnosed with unspecified injury of the head actually probably qualify for a diagnosis of concussion. But because we lack the ability to do a great assessment in younger children of concussion, physicians are sometimes reluctant to use the diagnosis. We also saw geographic variation in the incidence. This is just a map showing the geographic classification of different regions, the 2 metro areas of Edmonton and Calgary, large urban areas, Grand Prairie, Red Deer, Lethbridge, and Medicine Hat, and then rural and remote areas. And what you can see in the top map here, the top set of maps from 2005, 2011, and 2017, is the overall increase in the incidence of concussion, but clearly significant geographic variation. Interestingly, the highest rates weren't in the metro areas, but in several of the urban areas, but not all. And what this signifies is differences in practice variation within geographic regions that is not entirely tied to socioeconomic status, although socioeconomic status is a predictor as well of incidence. May also, these changes geographically likely reflect differences in practice variation as well as access to care. So other key findings of these studies was that the number of patients seeking care in outpatient settings, physician offices, relative to emergency departments has increased, so that we see an increasing percentage of these visits, both index visits and follow-up visits, occurring in physician offices rather than emergency department settings. However, patients from rural and remote areas use the emergency department for initial and follow-up visits more often, and socioeconomic disadvantage was also associated with increasing rates of care in the emergency department. When we looked at follow-up care, we saw that the incidence of follow-up visits for concussion had quadrupled over the 14-year period of the study, but most patients actually had episodes of care that involved a single visit with no follow-up. And given that follow-up care is recommended as a standard in most guidelines, we were interested in what predicted follow-up care. We looked at a variety of characteristics, including age, sex, the type of community a child came from, socioeconomic status, the year of their visit, the actual diagnosis they had, where they received care, whether in an emergency department or physician office, and whether or not they had had a prior history of concussion-related episodes of care. Out of almost 200,000 episodes of care that occurred over the study period, only about 13% involved follow-up care, or slightly over 25,000. All of the predictors we studied were significant predictors of follow-up. So follow-up care was more likely for males and adolescents. This could be in part because they need follow-up clearance to return to sport. Patients with a history or diagnosis of concussion were more likely to have follow-up than those with, say, a diagnosis of unspecified injury to the head. Patients with more than one episode of care, so that if you had a previous concussion, you were more likely to get follow-up the second time around. Episodes of care starting later in time, so because follow-up care has become more common in more recent years, and episodes of care starting in outpatient settings, probably because they returned to the same physician for the follow-up. Follow-ups were less likely for patients that lived in remote communities or those living in areas with lower socioeconomic status, again suggesting that access to care is a significant determinant of follow-up. Taken together, all of these factors did a pretty good job of predicting whether or not someone had follow-up based on a receiver operating characteristic analysis showing significant improvement over chance. So what can we do about concussion? Prevention is certainly probably the best option. The best concussion is one that's never happened. We can treat concussion in various ways. We're becoming increasingly aware that the treatment of concussion can be done much more actively than just passively waiting for children to recover. Another way to work around concussion is health system change, and that's really what I'm going to talk about today. So we know that there's significant variation in the practice around concussion. This is a study we published back in 2019, a large group doing a survey of 15 Canadian and United States centers looking at practice patterns for both pharmacologic and non-pharmacologic therapies. And what we found were significant variation across these centers, despite the fact that they were all tertiary care centers, and one might expect a bit more consistency in the care they provided. So back in around 2015, it seems a long time ago now, I was part of a work group called together by the Maternal, Newborn, Child and Youth Strategic Clinical Network and this the Strategic Clinical Network work group to develop a clinical knowledge document for acute concussion in children. The study team that was partly funded through the Health Outcomes Improvement Fund from AHS translated that knowledge document to an acute care pathway with significant input from multiple stakeholders. And the study we're going to talk about today was really sought out to determine whether implementation of that pathway would affect care and costs using what's called a stepped wedge cluster randomized trial. And I'll define that a bit here in just a second. The work was funded originally by the Health Outcomes Improvement Fund through Alberta Health Services, and we subsequently got additional funding from Brain Canada. This was a project done together with the University of Calgary and the University of Alberta, and at 4 different clinical sites that I'll talk about in a second. So the key research objective was to design an approach to implementation of the clinical pathway. So how do we actually put it into practice? And then evaluate the impact of implementing that pathway using what's called a stepped wedge cluster randomized trial. What that essentially means is that we randomized the order of implementation across our 4 sites. So we had a run-in period where the pathway wasn't being used at any site, and we implemented it at one site, waited a set amount of time, implemented it at the next site, and so forth, until in the very last part of the study, had been implemented at all sites. We went through 3 primary periods for the project. Initially, of course, we spent a lot of time developing the clinical pathway through consultation with a team of researchers, patients, clinicians, and IT specialists. We worked with frontline physicians and nurses at the sites. We had a study team that included people with lived experience, and we had IT specialists both locally at the university here in Calgary, but also Macromind that helped us to develop videos that were part of the web portal that I'll talk about shortly. We finalized the clinical pathway and the implementation plan and then conducted the trial. The trial was implemented in a way that provided relatively little direct on-site support because we wanted it to actually work as in real life, but we were available for consultation to each of the sites. We spent a fair amount of time trying to engage each of the sites in the implementation. And then after the implementation, we evaluated how it had worked. We tried to look at the outcomes and, of course, disseminate our findings. So one of the first and major efforts we made to try to design the pathway was to actually interview physicians and nurses from all 4 of our clinical sites about clinical pathways, particularly in concussion. And this set the tone for really changes in what we initially thought we would do versus what we actually did by highlighting the need for simplification to make it clinically relevant, to make a difference in how patients were actually discharged from the ED in terms of where they went and what kind of care they received. So the key components of the pathway included some physician and nurse resources. In particular, we introduced a validated risk score, the so-called 5P rule, that would allow physicians to determine whether to triage children to their family physician versus a concussion specialty clinic. We also arranged for direct referral to specialty clinics for high-risk patients and encouraged physicians to make referrals for follow-up care. We also developed standardized handouts about concussion that could be distributed to patients in the ED and tried to effectively reduce the variability in terms of the information that was being given to patients. We developed an electronic web portal that was meant to provide patients with accessible, digestible information to help promote and support their children's recovery. Also to allow us to track recovery with symptom ratings, allow patients and their families to provide feedback on the care they received and their satisfaction with the care, and assess adherence to recommendations. This is the 5P clinical risk score sticker, essentially, that we put on patients' charts. It's a fairly simple way of estimating the risk of persisting symptoms after concussion. This was published in JAMA back in 2016 in a study that we were part of here at the University of Calgary. If you have the patient's age, their sex, their history of concussion or migraine, their clinical exam, whether they have balance errors on a balance test, and then 3 symptoms, headache, sensitivity to noise, and fatigue, you're able to essentially total those up, and you come up with a score from 0 to 12. In the sticker, it showed that low-risk patients were meant to be referred to their family physician and given regular instructions for return to school and play. Medium-risk patients were also meant to be referred to their family physician with the potential of a referral to a specialized clinic if they were still symptomatic in 3 weeks. And for the high-risk patients, which were the ones most likely to have persisting symptoms, we recommended direct referral to a local specialist clinic. This is just an example of the tools that were used as part of the pathway. We had the direct concussion referral form and the 5P sticker. We had our standardized headache handouts about concussion and head injuries in general and about returning to school and sport. And this is just a screenshot of what the web portal looked like in terms of being able to report on symptoms, quality of life, and satisfaction with care. So we rolled out the pathway in 2019. Fortunately, we were able to complete this study shortly before the pandemic, so none of the results were affected by the pandemic. The 4 sites were Alberta Children's Hospital and South Health Campus, which we considered a single site because the physicians providing care overlapped substantially. Grey Nuns Community Hospital in Edmonton, Stollery Children's Hospital in Edmonton, and Northeast Community Health Center in Edmonton. We purposely selected both academic hospital settings like Stollery and Alberta Children's, as well as smaller, more local, regional kinds of care like Grey Nuns and Northeast Community Health Center, in order to see if the implementation of this of the pathway rolled out differently in the different sites or had different impacts on the outcomes we were interested in. So we initiated the launch of the study in January of 2019. We then implemented it first at Alberta Children's Hospital 3 months later, then Grey Nuns Hospital 2 months later, then Stollery, then the Northeast Community Health Center, and finally we completed data collection in November of 2019. So what I want to really focus on here is the publication that we had looking at the impact of the implementation of the pathway on the care that children received and the costs of care. And this is from a paper published in the Canadian Journal of Emergency Medicine back in 23. These are pictures of Ann Lee and Heather Godfrey, who were the research staff who really were critical to getting the project off the ground and making sure it was completed successfully. So across the year in the 4 sites, we had nearly 3,000 unique patients, roughly 2/5 female, 3/5 male. Median age of the children was 11 years. We purposely focused on children between 5 and 17, and about half of our sample ranged from 8 to 14. Those patients were engaged in a little over 3,000 emergency department visits, about 1,000 before and nearly 2,000 after implementation. Of those, they also completed 781 follow-up visits. That could be more than one for a particular patient. Most episodes of care involved a single visit, about 80%, and about 2/3 of the patients in the data set had been diagnosed with concussion or post-concussion syndrome, and about 1/3 had been diagnosed with unspecified injury of the head. The outcome measures we were interested in is whether or not children return to the emergency department. We hoped that that might become less common with the implementation of the pathway. We looked at outpatient follow-up visits, and our hope was that the implementation of the pathway would lead to an increase in outpatient follow-up. We looked at total length of stay in hopes that we might streamline care in a way that might lead to a reduction in the overall length of stay. But we also looked specifically at the time from triage to physician initial assessment and the time from the physician initial assessment to disposition, because it could be that the implementation of the pathway would have different effects on those. And finally, to look at cost, we looked at total physician claims per episode of care, and that would include physician time both in the ED and outpatient setting. So these are the results across those variables. There was no change in the proportion or probability of return ED visits. So we didn't reduce ED visits, but as it happened, there was a very low rate of return ED visits before the implementation of the pathway, and it continued to be low, less than 5% after the implementation. We did see a significant increase in follow-up visits. So the odds of a follow-up visit increased by nearly twice relative to prior to the implementation, and that the probability of follow-up visit actually increased by almost 15% from the baseline, which was around 20. So we went from about 20 to 35% in terms of the rates of follow-up. Interestingly, we actually saw a modest increase in the time from triage to physician assessment, around 12 minutes. Our sense, based on interviews after the implementation, was that the provision of this information actually reduced and led to a sense of perhaps a little bit less urgency for patients with these presenting problems. Perhaps more interestingly, we saw a significant decrease in the time from physician assessment to disposition of almost 24 minutes, consistent with the notion that the implementation of the pathway, providing standardized information using the 5P rule and providing patients with a online resource, helped to streamline care and make it more efficient. We didn't see any increase in physician claims overall. There was one of the 4 sites where there was an increase, but overall there wasn't. It simply continued the trend that with time there was a modest increase in physician claims in general. So we learned several lessons after we had these results in terms of how well the pathway had been implemented and the successes or failures that we had. It was really clear that the buy-in from clinicians, both nurses and physicians, varied both within and across settings, and the interviews told us why. Our sense was that the staff very much appreciated the resources. Physicians liked the 5P sticker because it had a strong empirical basis. It provided a reminder during assessment about the need for follow-up care, and the access to direct referral to specialty clinics was seen as a positive. The nursing staff appreciated having a single concussion handout that was consistent for all patients and not having to pick one or more. Some of the sites had 3 or 4 different handouts, and nursing staff often felt like they didn't know which one they were meant to use. But we also appreciated that there really needed to have been even more focus on frontline implementation. And in particular, we didn't have the time or didn't take the time to really demonstrate and get feedback about the online portal. And that may be part of the reason that, unfortunately, we had really very little clinical outcome data about the patients. The actual use of the web portal was disappointingly low to us. When we talked with families who had been in the study afterwards, these are mainly families here in Calgary, the feedback we got was that the families really were very happy with the paper handout and didn't feel any need for the portal. They were also a bit put off by the fact that the portal was set up in such a way that they had to log in and provide consent because of the requirements of informed consent. But that was probably a deterrent for many families. Some of them actually liked the idea of an app more than a website. People obviously increasingly likely to use their phone rather than going to a computer. And there were also issues around how the email could be used to try to get feedback from children versus their parents. So obviously, we're always interested in whether our studies have made a difference. Certainly academically, we published the paper on qualitative interview and on healthcare utilization, and we had the 2 epidemiology papers that were actually published as offshoots of this project. Within the healthcare system, our handout and the web portal were supported by Alberta Health Services, and the handout continues to be available under the AHS forms. The web portal was initially open to everyone after the project was completed, so that no login or consent was needed. But unfortunately, we didn't have any funding to update it, and we've now let it sunset because we don't want outdated information being provided. There were some online resources. HealthLink allowed patients to be referred online to get the handout, and My Health Alberta adapted the handout content to their format. So we feel like we did make a difference, and we saw some informal evidence that people continued to use the handouts, and that physicians, in some cases, continued to use the 5P rule to help manage care. Let's conclude here with a few take-home messages. We know that concussion diagnoses really have increased dramatically in the last 10 to 15 years. At the same time, there are significant changes in care that are happening as care shifts from emergency departments to physician offices. We also know that follow-up care is becoming more common. However, there are social and geographic disparities that affect the care for concussion. Care varies as a function of age and sex. It also varies geographically and as a function of socioeconomic status, with the latter two being important variables that affect access to care. Improving healthcare is possible, but to quote my research coordinator, changing practice sure is hard. Planning takes changes in care takes a lot of time and a lot of input. And successful implementation of any change really takes significant buy-in from frontline staff. You can't do this in a top-down manner, and we really learned the importance of getting feedback and engagement prior to implementation. It's clear that clinical pathways need to be practical, feasible, and make a difference in children's care. Interestingly, simple handouts may trump fancy websites for many families. It may be easier in some ways to implement decision and prediction rules in electronic health records. One thing we would have loved to see, and I hope might still happen, is to make the 5P risk sticker available as an actual tool in Connect Care. The 5P risk score is not protected in the sense of there's no cost to use it. It has been implemented in a few other settings electronically, and it might be something very helpful to physicians in emergency department settings to help manage. It's also, the 5P score has now been validated in outpatient settings, so it could be extended to outpatient care and increasing use of Connect Care in those settings. One of the things that we'd like to do eventually is look at whether or not the implementation of a clinical pathway and decision support in primary care would also improve the rate of follow-up care and outcomes for children with concussion. This is particularly important as the burden shifts somewhat from emergency department to physician offices in terms of the care of concussion. If you'd like more information about pediatric concussion, I'd recommend a really nice review article that two colleagues and friends of mine published in Lancet Child and Adolescent Health back in 2023. Very nice article about improving outcomes. If you want really state-of-the-art information on concussion management, highly recommend the Living Guideline for Pediatric Concussion. It was originally funded by the Ontario Neurotrauma Foundation on the Ontario Ministry of Health, but is now housed through the Children's Hospital of Eastern Ontario. The website here, there's a wealth of information there about managing pediatric concussion. Other guidelines are available through the Centers for Disease Control, the United States Concussion and Sport Group, and the Canadian Guideline on Concussion in Sport. I'd also like to just mention the Canadian Concussion Network. This is an organization that we started back in 2020 with a Network Catalyst grant from the Canadian Institutes of Health Research. Now have about 450 members across sectors and across trainees and scientists. That has really helped, I think, bolster collaboration and knowledge translation around concussion. The website, you're welcome to visit, and we do have an annual meeting with the next one scheduled for April, actually in Calgary. I want to acknowledge that all of my work, including the studies I've talked about today, are very much collaborative efforts. And I have collaborators all over Canada as well in the United States. And also need to acknowledge all the trainees and staff that really make it possible to do this work. And now I'm happy to say I've stayed relatively on time, and would love to have some time to answer your questions or have a discussion. And to do that, I'm going to stop sharing so I can uh, engage in some conversation.
Wow, thank you very much. That great information, and certainly excited about your important work. We do have some questions around Connect Care, and I think you partially answered that in your later slides. But can I ask, have you initiated the request to actually have the 5P in Connect Care at this
No,
point?
I haven't, in part because I don't have a direct clinical link to Alberta Health Services. My appointment's academic and not through AHS. I was hoping one of my spies in AHS, i.e., somebody like a physician at one of the sites where we did the study, might do that because it's likely to have a faster response. I probably need to bug Bruce Wright, who's my main contact at Stollery, or Antonia Stang here at Alberta Children's to do that. It's I think it's actually available in Epic and at least one other setting, although I'd have to double check that. So there may even be a smart phrase or some other tool through Connect Care where it could be relatively easily imported. But no, to the best of my knowledge, that request hasn't been made, although I could be wrong.
Okay, thank you. Um, if anybody would like to ask any questions or provide comment, please go ahead.
And the AHS forms, that's an interesting question. They told me that's what it's called.
Okay.
and and that's true also for the clinical knowledge document that was prepared through the Strategic Clinical Network Working Group. But I do know that it can be a rather Byzantine process to try to find these documents and the handouts. They were and should be still available, but I can't give you the pathway how to get there.
Okay. Thank you for that. I do have a question here. I really appreciate the take-home messaging slide that you had. You'd mentioned you'd published several papers, including your thought about the initiative for primary care. Are there additional areas or gaps that you think need attention for Alberta in particular?
In terms of concussion care, I think really one of the areas that we definitely see a gap is in primary care and the very limited amount of training that medical students actually get to concussion or traumatic brain injury in general. It's in fact it sort of maddeningly scant in terms of what they get by way of preparation. So we've instituted a couple of efforts to try to increase the amount of education that happens in the medical school curriculum, and we tried to get some funding, although we haven't succeeded yet, to do more in the way of outreach. Of course, primary care physicians, family physicians are incredibly busy. It's hard for them to set aside time to do this sort of training or educational outreach. It's important to make it accredited so it gives them CEs and other things. And we have plans as part of the concussion center that will be opening at the University of Calgary next year to make primary care physician continuing education a key focus of some of the work we're going to be doing because while there's still room for improvement, I think at the level of acute care in the emergency department, we are seeing an increasing number of these injuries coming to physician offices. They don't see the same numbers, so they don't have thousands of them coming through their door, but there's enough that we really need to help in that sphere. I think there are some good training information out there. There's a very nice component to what the CAT, it's an online training set of modules through the Injury Center in British Columbia, but it's available to anyone. It's free. There's a very nice module in there for healthcare providers and physicians. But again, it takes some time, for somebody to sit down and go through that. So it's always a matter of trying to figure out how to provide the most key information most efficiently that will make the biggest difference in the care of kids with concussion. And that's still certainly a priority for us and one that we're trying to figure out how to solve.
Thank you. And your electronic web portal, are you intending to continue on with that, or what have you decided to do given the
Yeah,
response?
it's it was disappointing in terms of for our purposes how the web was or portal was used, because we did pour a lot of energy into preparing video sort of tidbits that might help parents and information and so forth. The challenge with these websites or an app is that they have to be updated regularly because really, we even in the last 10 years, we've made some pretty significant advances in what we know is likely to work in terms of helping to reduce the likelihood of persisting symptoms and other issues or problems that people can encounter after concussion. And maintaining a website with accurate, up-to-date information, unfortunately, takes money and time. And with uh, the state of research funding, it's hard to do that. And since some aspects of the portal were developed just for research, we stripped those away. The rest of the information was helpful, and we did see some use of the portal after the project was completed, but we didn't have a way to maintain it. And I do feel like, based on the feedback we got, that the right direction to go in is probably an app rather than a website. The website was developed in a way that would be accessible on a phone, but was not really designed specifically to be phone friendly and app friendly. And there's a whole now, as you probably know, science and technology and art to developing apps. And you need apps that engage people, that provide not just probably information, but actions in terms of what they can do to promote their recovery. And there are a variety of teams that put together different apps around concussion. I don't think the perfect one yet exists, and a lot of them don't have much empirical evidence behind them, although, again, people are moving in that direction. Long-winded answer is that I think we felt that the trade-off in terms of what it would take to maintain the website and keep it up to date as compared to what its benefits were likely to be probably didn't warrant trying to find a lot of funding to do that, and instead supporting efforts to try to develop app-based sorts of interventions if we had the opportunity to do that.
Okay, thank you. That's all the questions I had. If there are any other questions, certainly speak up now. I can let you know that we had several people inquire if the recording would be available post-event.
Right.
And so we'll make sure that it is available. We'll email the registrants, and we'll also distribute the link organizationally as well for people who weren't available for this presentation, so that they can access as well.
Great. And the two of the publications I mentioned were included in the link. And I think you'll be sharing the PDF of the slides. So if anybody wants websites or references or so forth, those are all embedded there.
Great. Thank you so much. With that, I will stop the recording. Thank you so much for the presentation. It's greatly appreciated. Lots of important information, and thank you for conducting your research at our facilities. And I hope you continue to do so.
Thanks for the
Um,
invitation, and yeah, hope folks enjoyed it. And if there's any other feedback, feel free to send it along.